Lung development is an extremely important and complex process in human embryology. Its aim is to ensure a large enough surface area inside the lung to support gas exchange. This presentation will provide an overview of the stages of lung development. Lung organogenesis begins at about gestational week 25 and will continue into adulthood. The lungs develop across 5 sequential stages, but the actual timing of the stages is generalized, and some stages will overlap. The stages are embryonic, pseudoglandular, canalicular, saccular, and alveolar. The development of the lung depends on numerous complex relationships between genetic signaling and various physical, biochemical, hormonal, and structural factors. The first stage of lung development is the embryonic stage, which occurs during 3 to 6 weeks. During this stage, the general structural components of the respiratory system begin to form, including the larynx, trachea, and bronchi. The lungs appear by about the 4th week. Respiratory system development begins as the laryngotracheal groove appears on the caudal end of the anterior foregut, also called the primordial pharynx. By the end of the 4th week, the groove deepens and forms a pouch-like structure called the laryngotracheal diverticulum. The distal end enlarges to form the lung bud, which grows as 2 outpouchings of the foregut on either side of the tracheal primordium. As the laryngotracheal diverticulum separates from the foregut into the primary bronchial buds, it is accompanied by folding of the foregut, which separates it into the trachea and the esophagus. The undivided proximal parts of the lung bud form the trachea. In the proximal trachea, mesenchyme from the brachial arches proliferate and form arytenoid swellings. The swellings grow towards the tongue and convert the primordial glottis into the laryngeal inlet, which is a narrow slit. The laryngeal epithelium continues to proliferate rapidly, causing a temporary occlusion of the laryngeal lumen that needs to be recanalized by week 10. In the process, the laryngeal ventricles form. These are bonded by folds of mucous membranes and become the vocal cords. The laryngotracheal diverticulum separates from the foregut into the primary bronchial buds. This is accompanied by folding, which separates the foregut into the trachea and the esophagus. The lung buds continue to develop into the bronchial tree, with the right lung bud dividing into the 3 main bronchi and the left developing into the 2 main bronchi. Abnormal development in the embryonic stage is due to problems in formation or separation. Failure of the foregut to fully separate into the trachea and esophagus results in tracheo-esophageal communications or fistulas. It is best to become familiar with a few anatomical terms to ensure that you understand what is being discussed. A fistula is an abnormal opening between 2 parts of the body, so a tracheal esophageal fistula is an abnormal opening between the esophagus and trachea. Atresia occurs when a normal anatomical structure that should be open is absent, underdeveloped, or closed abnormally. Esophageal atresia refers to an abnormal or incomplete connection between the esophagus and the stomach, or the 2 anatomical structures that should be open. So esophageal atresia refers to an abnormal or incomplete connection between the esophagus and the stomach, or simply the 2 ends of the esophagus do not connect as they should. Proximal and distal relate to the center or point of attachment to the body. The proximal end of the esophagus and trachea refers to its proximity to the mouth, and moving down the tracts is the distal end. A tracheoesophageal fistula is a subset of combined anomalies of the trachea and esophagus due to abnormal development or separation of the foregut. It is often, but not always, associated with esophageal atresia. TEF and EA occur with a spectrum of anomalies, but it is best to describe the abnormality in the clinical setting. The TEF is classified based on the location of the fistula and its association with an esophageal atresia. Agenesis refers to the failure of an organ or tissue to develop during embryonic growth. Stenosis relates to the narrowing of a piece of anatomy. Tracheal agenesis is a rare malformation that occurs when the trachea's growth is entirely absent. Tracheal stenosis occurs when the trachea narrows. With these disorders, there may be a slight narrowing or a complete absence of the entire structure. Survival is related to the degree of malformation and timeliness of surgical correction. Without a fully functional connection between atmospheric air and the lungs, the fetus cannot survive extrauterine life without immediate surgical intervention at birth. The pseudoglandular stage occurs from around weeks 6 to 16. During this stage, the lungs resemble an exocrine gland and appear gland-like, surrounded by loose mesenchyme tissue. The lung buds expand, forming segmental airways while lymphatic vessels and bronchial capillaries develop. Cartilage appears between the 9th and 10th week. During about the 13th week, the epithelial cells in the lung buds give rise to other types of cells, including ciliated cells, goblet cells, and basal cells. By 16 weeks, all major elements of the lung have formed except those involved with gas exchange. Respiration is impossible during this period, so fetuses cannot survive outside the womb. Abnormal development during this phase can result in bronchogenic cysts, congenital lobar emphysema, and congenital diaphragmatic hernia. Bronchogenic cysts are poorly understood and are thought to occur due to abnormal ventral budding of the tracheobronchial tree. Bronchogenic cysts, also known as duplications of the foregut, are often found within the middle mediastinum or the mediastinal area, but may also appear in the lung parenchyma, pleura, or diaphragm, and may communicate with the airway. These single-chambered cysts are commonly present as smooth-appearing, spherical, and non-calcified masses containing clear fluid, blood, or air. Congenital lobar emphysema involves overinflation of one or more pulmonary lobes. It is thought to be due to disruptions in bronchopulmonary development secondary to abnormal interactions between embryonic endodermal and mesodermal lung components. A congenital diaphragmatic hernia is a defect that allows abdominal contents to migrate abnormally through the diaphragm into the thoracic cavity. It may occur in isolation or with other congenital anomalies. The thoracic cavity's abdominal contents occupy the space required for lung development. Because the space for growth is occupied, lung growth stops, resulting in pulmonary hyperplasia. The severity of impaired lung growth depends on the size of the defect and the amount of abdominal contents in the thoracic space, as well as its association with other disorders. The canalicular stage begins around the final weeks of the pseudoglandular stage and extends between week 16 and 26. This stage of lung development is extremely important because infants born late in this stage may survive if enough respiratory units capable of gas exchange are present. In this stage, the terminal bronchioles give rise to more respiratory bronchioles, and the pulmonary vascular structures rapidly develop. By about the 20th week, primitive type 1 pneumocytes, the cells needed for gas exchange, can be observed, and lamellar bodies, the cells that store surfactant, begin to appear in the type 2 alveolar cells, the cells responsible for producing surfactant. At about the 24th week, acini, the berry-like clusters of cells at the end of the respiratory bronchioles, develop and give rise to primitive alveolar ducts. Capillaries surround the acini, forming the primitive structures needed for future gas exchange. By the end of this phase, thin-walled primordial alveoli have developed and lung tissue is vascularized. A fetus born at this stage often will not survive due to the lack of surface area for gas exchange and the limited production of surfactant. A fetus born towards the end of this stage can survive given appropriate intensive care. However, along with the respiratory system, other body systems are also immature, which impacts the chance of survival. Infants born without adequate surfactant will experience surfactant deficiency respiratory distress syndrome. Surfactant is a foamy substance responsible for maintaining lung surface tension as it spreads over the air-liquid barrier of the alveoli, forming a thin coating or barrier. This prevents the lungs from collapsing at the end of expiration. When there is a surfactant deficiency, the alveoli will collapse, decreasing the surface area available for gas exchange and leading to respiratory distress. These infants will require respiratory support through invasive or non-invasive mechanical ventilation. However, even with appropriate and safe ventilation strategies, there is a high risk that the infants will develop lung injuries related to pressures in the lungs or simply the administration of high oxygen concentrations. The lecithin to sphingomyelin ratio and phosphatidylglycerol levels are tests that can be performed prenatally to assess the infant's lung maturity. Lecithin is produced by the fetal lung, while sphingomyelin is a non-fetal membrane lipid found in amniotic fluid and begins to fall by 32 weeks. ALS ratio of 2:1 indicates lung maturity. However, it is not accurate in infants of diabetic mothers. Phosphatidylglycerol production increases by about the 35th week. If it is present in the sample, it indicates lung maturity. The administration of antenatal corticosteroids accelerates lung maturity by increasing the surface area for gas exchange and stimulation of surfactant production. Corticosteroids administered 1 to 7 days before birth have been shown to reduce neonatal deaths and the occurrence of infant respiratory distress. However, there was no benefit if the infant was born within 7 days after administration. The saccular stage occurs between 24 and 36 weeks of gestation. During this stage, the amount of gas-exchanging surface area in the lungs significantly expands. The terminal airways begin to form clusters of enlarged air spaces called terminal sacs or saccules. Type 1 and 2 cells continue to mature, and capillaries invade the thin walls of the sacculi to form a blood-air barrier, forming a functional surface for gas exchange. It is important to note that while surfactant production begins by about the 24th week, it is not produced adequately until about the 32nd week. So the longer the fetus can remain inside their mother, the higher the likelihood that it will survive if born prematurely. Just as in the canicular stage, infants born with premature lungs are at high risk for developing respiratory distress syndrome requiring respiratory support. Exogenous surfactant can be administered directly to the infant's lung to improve lung compliance and stabilize the alveolar membrane, reducing alveolar collapse and atelectasis. Surfactant administration reduces the risk for and severity of respiratory distress syndrome and a 30% reduction in mortality. Invasive and non-invasive mechanical ventilation is available to support the premature infant until the lung grows enough to allow for unsupported respiration. Mechanical ventilation comes with many complications, such as the development of pulmonary interstitial emphysema and bronchopulmonary dysplasia. However, without mechanical ventilation, the infant would not survive. The alveolar stage begins at around 36 weeks gestation and continues to around 8 years. However, postnatal lung growth in both the number and size of alveoli continues into young adulthood. Infants born at this stage can support their breathing. However, complications with delivery, prenatal infections, too much or too little oxygen, nutritional status, and the availability of other nutrition factors like vitamin A and thyroxine can all facilitate or impede alveolarization. The development of the lungs is a critical process required for human life. While lung development is only a small part of the fetus's development, understanding the process can help providers identify the issues that can arise in postnatal life.